abdominal pain or vomiting for the patient. The patient is currently on medical management, that is dutasteride and tamsulosin combination for the past 1 year. The patient was a known case of type 2 diabetes mellitus for the past 10 years, controlled on oral hypoglycemic agents, and there is no history of any hospital admission for diabetes or chest pain, breathlessness or weakness of limbs, decreased urine output, vision disturbances, and altered sensations in food. Moving to personal history, the patient is a farmer by occupation, is on mixed diet. In bladder habits, is disturbed due to midnight awakeness due to passing of urine, and bowel habits are normal. He is a non-smoker and non-alcoholic.
Can you just summarize the positive points from your history?
Ma'am, the patient is a 75-year-old male patient with a history of weak urine stream, increased frequency of maturation, weak dribbling of urine, and incomplete feeling of voiding of urine after for the past 1 year. The patient is currently on medical management for reduced urine flow. And the patient is known as a diabetic patient for the past 10 years, controlled on oral hypoglycemic agents, and is controlled.
What is your probable diagnosis for this case?
Since the patient is an elderly male, this also points towards a diagnosis of benign prostatic hyperplasia, and the patient also complains of symptoms of BPH like increased frequency of urination.
What is this benign prostatic hypertension?
Benign prostatic hyperplasia is non-malignant enlargement of smooth muscle and epithelial cells of the transitional zone of the prostate gland, which leads to urinary flow obstruction.
Okay, so that is the significance. That's why the patient is having
Symptoms
this dribbling of urine, and also it will be disturbing the patient for during night. Okay, so what are the different managements?
There are
How this patient came to us?
Madam, patient came with obstructive symptoms. We can either go with medical management or surgical management in this patient. Medical management is mainly done to reduce symptoms of obstruction and also reduce the size of the gland. Medical management include 5-alpha reductase inhibitors and also alpha agonists. 5-alpha reductase inhibitors include dutasteride and finasteride. Alpha agonists include prazosin, tamsulosin.
Okay.
And surgical management.
Okay. Any other comorbidities for this patient?
Yes, madam. Patient is a known case of diabetes since 10 years.
Okay.
His diabetes is controlled on oral hypoglycemic agents.
Yes. It is very well controlled with the oral hypoglycemic agents. What are the clinical significance of this comorbidities for this patient?
As diabetes itself is related to diabetic ketoacidosis, we can expect diabetic kidney disease. There are symptoms of...
it is very well controlled. Then how can it be diabetic ketoacidosis?
Diabetic kidney disease.
What is the commonest complications for diabetes in this case?
Madam, diabetic may be associated with acute complications and also chronic complications.
Yes.
Most commonly occurring acute complication is hypoglycemia.
Yes.
We can also see diabetic ketoacidosis and also hyperosmolar hyperglycemic state, and chronic complications include macrovascular and microvascular
so
complications.
All this can be explained in a patient with uncontrolled hypertension. So for this patient, this diabetes is, the significance is that the patient may develop the frequent urinary infection. So that can lead on to what?
Increased
that can lead
risk
on
of
to
bleeding in the
uropathies. Uropathy. What is meant by this uropathy?
Autonomic uropathy.
Yeah, okay. Then, because there is, on examination, the blood urea can be increased. That is because of this obstruction. So that itself can cause this uropathy. Okay. So for that, what is the management?
Obstructive uropathy can be managed with catheterizing the patient.
Yes. What's the minimum duration for this catheterization?
1 week.
Only 3 weeks.
3 days.
Because since it's a elective case, we can wait for 3 weeks, isn't it? So, and at the same time, we can rule out the urinary tract infection also. So these are the 2 positive findings that you have. Otherwise, the patient is a non-smoker, non-alcoholic. Nothing is positive in this case, isn't it? So you continue with your examination findings.
Moving to examination finding, general examination, the patient is conscious, well-oriented time, place and person. He was moderately built and well nourished. He has normal facies. There is no pallor icterus, clubbing, cyanosis, lymphadenopathy or edema. Patient's BMI was 22.9. Vitals, he was afebrile. Pulse rate was 70 beats per minute, regular in rhythm, volume character. There was no vessel wall thickness, no radiofemoral or radial delay. All peripheral pulses were felt bilaterally equal. Vitals, BP was measured as 130 by 80 mmHg in the right brachial in sitting position. Respiratory rate was 14 per minute, regular abdominal thoracic. SpO2 was 99% at room here. Air examination, there was no facial dysmorphism, retrognathia or organatism. There was no loose teeth or artificial danger. Mouth opening was more than 3 finger breadth, and thoracic distance was measured to be more than 3 finger breadth in distance, and temporomandibular joint was more than 1 finger, and neck movements were adequate, and myometry was class 2. Spine examination, it was normal alignment and curvature. The spinous fossa was palpable, and interspinous distance was normal. Systemic examinations were done and all were within normal limits. Correct examination was not done. Moving to summary of the case. 75-year-old male patient, known case of diabetes mellitus for the past 10 years, controlled on oral hyperglycemic agents, presented with complaints of increased frequency of micturition, dribbling of urine, sense of incomplete bladder emptying, and weak urine stream since the past 1 year. Diagnosed as a case of benign prostatic hyperplasia on medical management.
So a diabetic patient with the 10 years of history, if they were coming for surgery and anesthesia, what are the positive points that we have to look for?
We have to rule out any complications due to diabetes, which might be microvascular and also macrovascular complications.
Okay.
Microvascular complications can be diabetic retinopathy should be ruled out, diabetic nephropathy should be ruled out, and diabetic autonomic neuropathy, in which patient might be having resting tachycardia, orthostatic hypotension, silent MI in the past, and there might be chances of increased gastroparesis in this patient, which leads to increased risk of aspiration, and also dry skin patient will be having. These are the diabetic autonomic neuropathy symptoms, and macrovascular complications might be coronary artery disease in the past. Peripheral artery diseases can be ruled out, should be ruled out in this patient.
Okay. So all these investigations that we have to do, and you have to rule out all these complications. So this patient that is coming for this TURP, benign prostatic hypertension surgery, isn't it?
Yes, ma'am.
So what is the significance of anesthesia point of view?
Ma'am, since the patient is an elderly male, the patient will have compromised physiological status, and we have to detailed evaluation of each system should be done, including cardiovascular system, respiratory system, musculoskeletal, and renal system. In cardiovascular system, there will be the muscle contraction will reduce, leading to diastolic dysfunction, and the vessel wall thickness can lead to increased systolic blood pressure and leads to left ventricular hypertrophy, and aortic valve sclerosis can also occur. And as age advances, there are increased chance of arrhythmias as well as conduction defects can set in. In case of respiratory system, there will be reduction in the compliance of increase in the compliance of lungs and reduction in the compliance of chest wall, and the closing volume will be much more greater than FRC, leading
Yes,
to
all these systems we have to examine in detail, and at the same time we have to have the investigations also.
Yes, ma'am.
So, what is your plan of anesthesia for this?
plan for anesthesia, spinal anesthesia.
Spinal anesthesia. Okay. So, how will you proceed with this case? Spinal anesthesia, not it's a regional anesthesia procedure. So, you have your selected spinal anesthesia, isn't it? So, how will you proceed with this case?
Madam, on the pre-op day, I will be visiting the patient in the ward. I'll be taking detailed PEC
Do you
of the
want to
patient.
have investigations for the
Yes.
case? What are the investigations that you want to do?
Investigations needed in this case include blood grouping and also serology of the patient. Blood should be made, but blood should be arranged on the day of the surgery, as we are expecting bleeding in the surgery. And we have to know complete blood count of the patient. Hemoglobin, baseline hemoglobin should be known, and total count to rule out any infections. Platelet and coagulation profile of the patient, which include PT, INR, APTT, should be seen, should be checked.
What is the relevance of coagulation parameter diabetes in this particular patient?
As TURP surgery itself is, there might be complication of dilutional coagulopathy in this patient. We have to calculate, we have to do baseline investigations, and
Yes.
if any derangement, we have to correct those derangements before taking patient to the operation theatre.
Yes. Next.
Blood urea and serum creatinine of the patient should be done, because to rule out obstructive uropathy and also diabetic kidney disease we are expecting in this patient. And serum electrolytes of the patient should be done, which
What is
includes
the
serum sodium.
relevance of serum electrolyte in this particular patient?
Serum sodium is very important in this patient, as there might be chances of dilutional hyponatremia during TURP surgery. So serum electrolyte, if any derangement is there, we have to correct it.
Preoperatively. Okay.
Glycemic conditions of the patient, which include fasting blood sugar and postprandial blood sugar, glycosylated hemoglobin of the patient should be done before taking to the surgery. Baseline ECG to rule out any history of any silent MI in the past, and also rhythm abnormalities, any arrhythmias, and also left ventricular hypertrophy. X-ray of the patient is done to rule out any chronic pulmonary disease, which is more common in this age group. And echo of the patient is done to check ejection fraction and to rule out any regional wall movement abnormality, and also to check diastolic dysfunction of the any diastolic dysfunction, and also to check any valvular disease in this patient. And also urine routine examination is done to rule out any infections, and USG abdomen is taken to assess the size of the gland.
So all this investigation shows that the patient is not having any abnormality at present. So we have to check all these things, because we have to know, identify any complications that may develop in the perioperative as well as in the postoperative period. So what is the clinical significance of this hemoglobin?
Ma'am, we are suspecting hemorrhage in this patient in the bleeding in the intra period, so we have to know the baseline hemoglobin levels in this patient.
Okay. Okay. And also in the ECG, chest X-ray and echo also, you have to know the basic values. Then only you can identify any complications might have happened. So how will you prepare? How will you optimize this patient for surgery as well as anesthesia?
Madam, on the preoperative day, I'll visit the patient in the ward, and I'll introduce myself, and I'll take detailed pre-anesthetic checkup and clinical examination of the patient is done. I'll build a rapport with the patient, and after every examination, I will explain patient about NPO guidelines, and also informed written consent is explained. I will explain about procedure and plan of anesthesia given and complications associated with them. And I'll be giving the patient, I will tell which drug to be taken and which drug to be omitted on the day of the surgery. And also anti-aspiration prophylaxis, which include pantoprazole 40 mg and also ondansetron 4 mg will be given on the day before surgery and also on the day of surgery. And anti-anxiety drug alprazolam will be alprazolam 0.25 mg given on the day before surgery, and it is avoided on the day of surgery to maintain consciousness of the patient during
Why do you
intraoperative.
want to maintain the consciousness of the patient?
Madam, as TURP syndrome is, the symptom of TURP syndrome is restlessness and altered consciousness. So in order to maintain consciousness of the patient, in order to early diagnosis of TURP syndrome will
To
be not
identify
avoiding.
the patient's consciousness as well as the change in the mental status of the patient, we have to keep the patient preferably in the conscious position. So suppose if we are, do you want to give any other sedatives to the patient? Which are the sedatives that we are commonly giving?
Midazolam can be given on the day of surgery.
Usually we won't recommend midazolam in a 75-year-old patient. Okay. Okay, you have to explain how it is done, and also what are the problems with the spine of the patient at this age.
There will be loss of lumbar curvature of the spine, leading to ascent of the drug.
So it may be difficult for us to get the
Spinal anesthesia.
spinal anesthesia for this patient. So then what are the fluids that you prefer to give in this patient as intravenous fluid therapy?
Intravenous fluid of choice is normal saline. 0.9% normal saline, madam.
Why do you want to give normal
madam,
saline?
As we are expecting hyponatremia in this patient, it is
Usually for all cases we are giving ringolactate, isn't it? Ringolactate we are giving for all these cases, not for this one, not for this TURP case. For all other patients we are giving
balanced salt.
Yes, balanced salt solution or ringolactate. Why do you want normal saline for this patient?
As we are expecting hyponatremia in this patient in post-operative period to prevent that.
And also to prevent
Metabolic.
what's the level of chloride in this normal saline?
154 milliequivalent per liter.
So as we are giving more,
Hyperchloremic
and
metabolic
also if the patient
acidosis.
is going in for hyponatremia, we have to give normal 3% sodium
Normal
chloride
saline,
also. So in such condition, what will be developing? Patient may
dilutional
develop hyperammonemia.
hyperammonemia.
So how will you prevent it?
Hyperammonemia is prevented by giving.
Hyperammonemia will cause what all things?
Hyperammonemia leads to cerebral edema and also it might
Yes,
cause
okay.
seizures. So it can be prevented by giving L-arginine, which prevents hepatic release of ammonia and also helps in conversion of ammonia to urea.
Okay. So what is the fluid of choice in this case?
For irrigation,
In the intraoperative period?
normal saline and also
Yes, what are the irrigation fluid that they will be giving?
Madam, ideal irrigation fluid should be transparent, non-hemolytic, non-toxic, and should be easily available and easily sterilizable. There are many fluids of choice. Most commonly used is glycine, 1.5%, and 1.2% is also available. There is also distilled water, ringolactate, normal saline, 0.9%. Sorbitol 3.5%, mannitol 3%, or there urea 1% is there. There's another solution called Cytal. It's a combination of sorbitol and mannitol, and there are also glucose 5%.
So the preferred fluid is 1.5%
Glycine.
glycine. What is the osmolarity for this glycine?
Madam, it's 220.
1.5%.
1.5% is 220, madam. It is hypoosmolar.
So even then we are using it. Why?
Madam, because it's transparent and the field will be clear and
So
it's
the field will be
clear.
clear. Okay. So because of that, they will be preferring this 1.5%
Glycine.
glycine.
Yes, ma'am.
Okay. Then what are the problems with that?
Madam, even though it has advantages, it can cause, it can convert to ammonia in the liver, can lead to hyperammonia, and can precipitate hyperoxaluria and hypocalcemia.
So what are the other complications that you have to expect in the intraoperative period?
Complications can include
Intraoperatively, complications can be due to patient itself or also due to position or due to surgery.
How will you position the patient after giving spinal anesthesia?
After giving spinal anesthesia,
What is the
patient
volume of the drug that you prefer to give?
Madam, in this case, we used 1.8 ml of 0.5% heavy bupivacaine along with 60 micrograms of buprenorphine.
Okay.
And after giving the drug, patient is lied in supine position for 5 to 10 minutes for the drug to get fixed. And
Why you are preferring buprenorphine for this?
buprenorphine post-operative analgesia, madam.
Yeah, okay.
And after fixing the drug, like 5 to 10 minutes, we'll be positioning the patient in lithotomy position. In lithotomy position, both the patient's
What's
legs.
the advantage? What are the effects that is occurring? After 2 to 3 minutes, you will change the position to lithotomy.
Position.
So what are the changes that will occur?
Madam, in lithotomy position, the patient's leg is flexed at the hip joint as well as the knee joint, and by doing so, there will be compromise of the compression of the nerves can occur, as well as cardiovascular and pulmonary compromise will be there. There can be increased chance of
The level of the blockade may get
may rise.
ascend up. How much is required for this patient?
Ideally, we need block up to T10 level to prevent.
Why do you need a T10
Madam,
level?
to prevent the discomfort caused by bladder distension of irrigating fluid.
Okay, in the intraoperative period, bladder distension may occur. So, in order to tolerate that,
needed
They,
blockage
we
of
have to give only up to T10-11. Okay, then
and complications can due to gastric aspiration regurgitation can increase due to the electron position, and complication can also occur post-op period after repositioning also. Hypotension can occur when the leg is straightened post-op period also.
What are the other complications that develop during intraoperative period?
There might be hypotension due to spinal anesthesia, due to peripheral pooling of the blood, and glycine toxicity can be expected, hyperammonemia, hemorrhage, and perforation of bladder and also prostate capsule, and there will be hyponatremia.
Yes.
And
What is the first symptom of TAP syndrome?
TUR,
So the first signs includes altered mental status and restlessness of the patient will be there. Then as it proceeds, it can move to nausea, vomiting, and eventually it can lead to seizures, coma, and
How will you manage it?
first of all, we have to early identification of symptoms and signs of TERP syndrome is very important during intraoperative period.
Okay.
We have to immediately inform the surgeon regarding the same and ask him to stop the surgery and achieve hemostasis. We have to reassure the patient and maintain airway breathing circulation of the patient is maintained. If there is any seizure episode, we have to manage it with intraoperative. Benzodiazepines like midazolam can be given, and we have to can give furosemide can be given 20 to 40 mg can be given to decrease the fluid overload, and we have to send stat investigations which include hemoglobin level of the patient, serum osmolarity, serum sodium levels, and ECG of the patient should be taken.
How can you reduce this complication during this intraoperative period? Otherwise, what is the rule of 60?
So the complications can be reduced by if you reduce the size of the gland to less than 60 gram,
Yes.
if you reduce the height of the irrigation fluid to less than 60 centimeter above the pubic symphysis level of the patient, if you reduce the duration of surgery to less than 60 minutes, all these can reduce the incidence of TERP syndrome in the intraoperative period. You can also reduce the incidence by preserving the prostatic capsule and correcting preoperative hyponatremia if there is any.
how will you identify if the patient has developed bladder perforation or bladder injury?
If there's bladder perforation or bladder injury, ma'am, the patient will have complaints of periumbilical pain or pain in the shoulder tip. She can also complaints of suprapubic pain also.
And also, you have to monitor
Monitor the irrigation fluid volume which is coming out. Is
the urinary catheter is draining less of the fluids. The output will be
Reduced.
becoming less.
Less.
So how will you manage it?
extraperitoneal rupture, we can go with conservative treatment like catheterization. Intraperitoneal rupture will be needing surgical corrections.
So how will you manage it? Suppose you have identified the bladder injury.
We have to maintain airway breathing and circulation of the patient, and we have to inform the surgeon.
We have to inform the surgeon and try to reduce it. The same management as that of advanced
TUR.
TURP syndrome. Okay. Then, what are the things that we can do? There is no role for us. They have made the bladder injury, and we can't
Surgeons
do. But in TURP syndrome,
We can correct if any hyponatremia is there. We can correct. We can
Yes, okay.
Reduce the fluid overload by giving Lasix, furosemide.
you have to do the immediate investigations for that. Then only we can identify if it is due to hyponatremia and all. And suppose if the patient is developing cardiovascular failure, and also patient is going in for hypothermia. What are the goals of anesthesia in the intraoperative period for TURP?
Intraoperative goals include like adequate analgesia and providing proper relaxation, bladder relaxation, so that surgeon can operate freely.
The
and also
hemodynamic stability.
Hemodynamic stability.
Yeah. Okay. Then then adequate post-op analgesia that you have already discussed. Okay. So in such case, suppose if you have diagnosed, if you are suspecting TURP syndrome, how will you manage it? Inform the surgeon.
And we ask them to attain hemostasis, and after that we'll be changing the irrigating fluid to normal saline.
In which position will you keep the patient? Will you keep it in the lithotomy position itself?
No, madam.
No. So we have to change the position.
to the supine
and at the
position.
same time, we have to keep the head end of
Hemodynamic
the
stability.
patient a little bit higher,
Higher.
so that we can give adequate oxygenation for the patient as well as better ventilation if it is required. Okay. Then what? Huh? What are the postoperative complications?
Post-operative complications we can expect include, as TURP syndrome can occur up to 24 hours, we have to be very cautious. And also post-operative myocardial ischemia can occur, bleeding chances are there, bladder spasm can be there, hypothermia, and also clot retention, DVT, deep vein thrombosis can be expected, and also septicemia.
Suppose patient is refusing regional anesthesia. What is your next plan of anesthesia? Patient is refusing regional anesthesia.
General anesthesia, we would go with the general
What are the
anesthesia.
concerns in this particular patient?
In this particular patient, like as TURP syndrome is also like main first symptom is
Now,
altered
what about the
consciousness. We
airway?
have to.
Patient is having a history of diabetes mellitus for the last 10 years. Anything wrong with the airway?
There will be chance of stiff joint syndrome in this patient.
Okay.
Difficult airway will be there.
Okay. How will you identify this in the preoperative period or PAC?
Like we'll be examining the airway of the patient.
Okay.
And the joints include
What is palm
atlanto-occipital
print
joint.
sign? Palm print sign?
Palm print sign in this patient's palm is painted with black color and placed on the white paper. And there are four grades of it: 0, 1, 2, 3.
Yes.
In 0, all the interphalangeal joints are visible.
Yes.
In phase 1, 4th and 5th are not interphalangeal joints are not visible. In the second phase, 2nd to 5th interphalangeal joints not visible. In 5th, only digits of all the fingers
So
are
what is
visible.
prayer sign?
Prayer sign, when we ask the patient to oppose hands of the both patients together, patient cannot do it. That indicates positive sign.
Okay. The patient is having severe shivering in the immediate postoperative period. How will you manage it?
Shivering can be managed with giving warm fluids, forced air warmers, and also we can go with the drugs like tramadol, and also pethidine can be given.
Will you give oxygen in this particular?
Yes.
So why you are supplementing oxygen?
Due to shivering, there is increased metabolism of the patient. As these patients are more prone to cardiac compromise, it will be more complicated.
Thank you.
What is frailty index? We are crossing this time. Frailty index.
Frailty index, it has 5 grades, 5 components, like unexplained weight loss of more than 5% in the past 1 year, slow walk, and reduced grip, and reduced physical activity.
So all of you can read. All the PGs can read what is meant by frailty index, what is the clinical significance of that. We are not going into details because of the shortage of time. Okay, thanks a lot for Madam for giving us a chance to participate in this ISA MedCon. Okay, thanks, ma'am.
Thank you for this amazing session.